Hello, this is Dr. Bill White again, and I'm going to try to talk about the second phase of this Bill White's Big Daddy arch wires. Now, I'm a general dentist that does nothing but orthodontics and some TMJ work, and I've done nothing but this for the last 40-something years. Started in 1970. Just doing nothing but orthodontics. I hope you're members of the American Orthodontic Society, and this is a wonderful society, and I had the privilege to be a charter member of it, and am pushing it more or less. If you're a dentist doing orthodontics or pedodontist, we encourage you to join the American Orthodontic Society. I'm going to start in here with the second case. We covered the mechanics of it to start with in the first case, and this next case we have here is a lady that, no, it's a young man, I'm sorry, that has a tremendous crossbite on the left side of the mouth. In fact, it's what we refer to as a scissor bite. The lower molars miss the upper molars and kind of go up on the side of the upper molars on the left side of the mouth. Looking at him from the facial structure, you just don't notice much of this at all. But as we go in here and have him open his mouth a little bit, here you can see the cuspid teeth are giving some problem, and slight variation in the jaw seems to be over to this side slightly, but shows very little outward appearance of this problem that he has. Here now we look in the mouth, and both upper cuspids are kind of crowded out of place. The midline is not far off. The cuspids look pretty good, but when you look back in here, these lower molars completely miss the upper molars, and so we don't want to take any teeth out on this young man, so we're going to expand the upper arch enough to bring these cuspids into place, and we'll expand both sides of the upper arch to aid in placing these cuspids and placing all these teeth in the right position. We'll also open the bite in doing this, and we're going to put some unilateral expansion on the lower arch and bring it way on out. Even though the upper will be out here further, we're going to bring this lower arch off. It's not quite a half inch, but it's going to come out quite a ways, and we're going to do a unilateral type expansion, and we'll hold this relationship over on the right side of the mouth. Now, when you look into the left side, the bicuspids meet fairly well, but as we get to the molars, they actually miss the upper molars and they slide down on the side of it. So we've got a long way we have to move these teeth out. Now, I've said for years now that if you move a group of teeth together, you'll move the bone structure. The alveolar bone structure will move right along with the teeth. You don't have to go in there and surgically section this off and move it out simply because the bone's not in here. And we're going to compare this with a case where somebody did not believe this. I'm going to show you the difference in the two, hopefully, before we get through with this. Now this we're going to expand out, so we had to bring this even further on the bottom to match these teeth up. And the bone structure is still on these teeth, so people just don't believe that, but it's hard to get that across. Now the right side of the mouth is fitting in a pretty good relationship in here. No problem there, so we'll expand this, and we'll also expand this a little bit on the bottom to match up with that. As we expand this, we'll bring these cuspids down into place there. So you can watch this as we go along. Now, excuse me, when we look straight down on the upper arch, we just need some more space in here to bring these cuspids back in. And so we're going to bring this out a little bit, and this probably out some too. And we'll slide these cuspids back into place and make this arch bigger than it is, and then we'll have to bring the lower even further out to match up with that. Now go on the lower arch. Doesn't look all that out of shape here, but these molars are actually coming up, and the upper molars are actually missing them, coming down like that. So we'll try to get a shot here that'll show that a little bit better. Now from the inside, just looking from the inside of the case, and you can take this down. We started it in 4 of 89, and the lower molars are sitting in here, and the upper molars are coming on the outside. That doesn't show it quite as good as I would like to, but maybe we'll get another view of it. Yeah, this is better here. It shows the upper molars actually touching on the buccal side of the lower molars. And so we're going to have to do a lot of expansion about in this area, and we also expand this out, so it makes us have to bring these on the bottom even further out to get them to occlude up here. Now, a lot of people don't think the bone structure will move along with the teeth, but I've been preaching this for several years, that the bone structure moves along with the teeth. If you just take a group of teeth and expand them, the alveolar bone that supports those teeth goes along with it. Now if you just take one tooth and want to go out, or a bicuspid or something, and leave the others, then you might be able to strip the bone off the tooth and the tissue off the tooth, bring in one tooth out. But when you bring a group of them out, the alveolar bone goes along with it. And I don't have any double-blind studies to prove that the basal bone also changes over a period of time down here to more efficiently support the alveolar bone, so the basal bone would change on its own, and you don't have to go in here and section the jaws off or do something drastic to move the teeth out so they'll have bone on them. Now that's something I've tried to get across for years. Now here we come in. This is about the Big Daddy archwire, how you expand with the Big Daddy archwire. So we put one in here. This is the side that doesn't need expansion, so we're going to actually expand this upper some also, and there'll be some expansion in this side. It won't matter as long as we keep it matched up with the upper arch. Now the way we do this to keep this side from going a lot further than it should is we run elastics from the molar going across and come in on the lingual of the upper molar, you see, into the buccal of the lower molar. It's not real plain right there, but you can kind of understand. We just use molar crossbite like if we had the lower molar here and the upper molar coming in, something like that. And to keep this from going too far, we run an elastic from here up to here, and that pulls this tooth back as it pulls this tooth out right here, and that'll keep these teeth in line while we're putting a lot of expansion on the teeth from both sides over here, and it'll make the expansion, basically all of it, come in the left side of the mouth, whereas at the right side you'll hold it in position while you're doing that. So you can watch this happen in here as we go along. So here we've hooked this deal up, and we started it, I think, forgot exactly how long it'll take us to do that. But if you move this group of teeth out, the alveolar bone structure goes right along with the teeth. If you do it a group of teeth, I've done thousands of them. I've never run one out of the bone that I know of, and people just, they don't buy that though. Now that we've got CT scanners, maybe we can prove it, but we just got one, and I don't have time enough in my life to do cases enough to give you some absolute proof on it. But we have CT scanners now in offices, a lot of offices, but I don't have any cases showing that. But I can show you how the bone must go out with these teeth. So anyway, that's the big arch wire put in there, and it would be way out away from here. So we pull it in to activate it and pull it in from over here. Now it's pushing the same amount over here as it pushes over here. And the way we come in with crossbite elastics, we also use elastics over here to pull this in. So that'll pull this back on the upper and bring the lower even out further on this side with the crossbite elastics. Now I think during the time we use class 2 elastics at the same time, but when you look at them, it looks pretty confusing without having depth. Now this class 2 elastic, this is the molar crossbite elastic here, and this is the class 2. They look like they're almost in the same plane here, but they're not. This is in the molar area, and so the expansion that is taking place will nearly all be on one side rather than over here. We expand this a little bit, also we expand this a little bit, so we don't mind that as long as we keep the teeth in the right relationship as we come across here. Now we'll come back and show this. I forgot the starting. Okay, we started it at 1189. Apparently this is the first starting right here. We've got the 11 of 89 right here that we started this case. We'll see how long it takes to bring this out. Now these teeth are leaning like this, so we don't have to put any torque in them. As we come out with them, they'll be more or less straight up and down in this area to meet the upper teeth. Okay, there we go. This 11 of 89. We're started. We've already expanded this out enough to bring the cuspids in. You see, we've got pretty well taken care of the upper arch before we actually start really pushing the lower arch out. Now here is the lower arch, and this is 4 of 89. That was when I first started the case, and I took this arch wire that we used and just, you make it to fit, and then you, after it's fitting, then you expand it. And so we've got a little over ½ inch expansion on that wire. We'll pull it in and tie it to these teeth in here, and the arch wires come in here, so it brings all of these out. At the same time, we'll hold these pretty much because of the elastics and the added force over here. The primary part of the expansion is going to be in this arch on the left side of the mouth as we go. Now here we're using, you see the class 2 elastics at the same time that we'll be using on the case. And this is starting is still 1130 of 89, and there's January of 90 now, so that's 1130 January 23rd. That's a couple of months just about, and we pretty well have these teeth out in that area in that length of time. Now there's a bony ridge right along here, and you can palpate it with your fingers, and you can see it. You don't have to even palpate it, but you can see the bony ridge. And so the alveolar bone came out with these teeth as they expanded, and then during that we were pulling with a class 2 elastic that has a little more expansion effect on it, and the cuspids we've brought right into place right now on that in that situation. Here now the upper arch is pretty much like it was. We've got some expansion on it also, and now the lower arch is out there. And this is January 23rd of 90, and it was 11 of 89. I think it's 2 months more or less that it took us to do that expansion. Now, if these teeth, they moved not a half inch, but they moved quite a bit coming out here. Now, if they had moved out of the bone over here, then what happened to the bone here? The lingual bone is still there. You can see it. It may look a little thicker than the lingual bone over on this side, on the other side of the mouth, but the teeth are still in the bone. And I have not been able to get that message across to people. And so they do a lot of cutting and a lot of stuff that to me is not necessary. And I'm going to show you a case right after this where they did some ridiculous stuff. And if they had realized this, they wouldn't have had to done that. Whereas we going through the case, midline's kind of off at this point, and this is 4 of 90, so another 4 months. This picture was distorted over here. This actually is lined up pretty good, but it's back when I couldn't redo them, didn't have these digital pictures. They really helped out a lot, but I didn't have them then, so I had to keep that. So here's 4 of 90, and these teeth are out meeting quite good in this relationship over here, whereas they were missing, and we expanded this even more to bring them out to go underneath there. And I'll guarantee you there's bone structure on these teeth, and I don't have the definite proof, but I think the basal bone will shift in this guy's jaw to where they support the alveolar bone, which supports the teeth, and the whole thing is going to change over a period of time, which you take some time doing this. Now that's 4/17 of 90. That's the uppers off there again. Alright, here's the lower again. We'll run through this pretty quick, but we're back in a good class 1 relationship. The cuspid's fitting right down that slot. Now, it was crowded out and this was off. This is pretty much in class 1 as we go back, and this is kind of a super class 1 molar relation back in the back. Now the other side is not quite as solid class 1 as the other, is the right side of the mouth. The left side, the one that was off, is not quite as far out like that. Here's the young man later. Now this is 91, January of 91. This tooth hadn't come all the way down. We got the arch wire should be, the bracket should have been further up on the tooth apparently to bring it back in here. But this tooth is touching too much. Now this will adjust when you take them out of braces. You use a proper type of retainer, and it'll allow this tooth to erupt into the mouth further. That bicuspid right there will come in contact. So I always tell everybody the final movement of the teeth is not when you got braces on them. It's when you take them out of the braces and you put them in retention. It has nothing over the occlusion. The teeth have got to erupt into each other and work out their condition between the two teeth, and they grind each other in over a period of time. And you first take them out of braces, you can see space through here, and you go a few months and those spaces go away. But these ridiculous retainers now that they use have wire coming up in here and then another wire back here with a clasp and all this, and have them chewing on the wire, and the teeth move one way when they're got the retainer in, and they move another way when they take it out. And this another problem I have in telling people, get rid of those type of retainers. Use nothing but a labial bow that comes out. You do not need anything to hold the retainer up in there. We have labia wire going around here. If you have a problem keeping it up in there, you can put a little composite under it, but have nothing under the occlusion on your retention, and nothing during the operation either, preferably. Okay, here's the other side, January, and I'll go through these pretty quick. I don't think there's anything remarkable to show. I'll show the x-rays on this guy. This is the x-ray after we've expanded. The bone structure on the x-ray looks about as good before we did it. I mean, after we finished it, it did before we started. There it is in 90. You can't see a great deal of difference in it. Now these teeth that move a lot, you'll see a big periodontal membrane change in there, but you leave it alone. That's not a pocket or anything around it. It'll fill back in with bone structure unless you destroyed the attachment or something. Okay, now this is pretty close to the end. That's kind of a super class 1 over here, and not so much class 1 on the other side of the mouth. Here's the young man after we finish. Now there's where the case was. This was class 2 molar, class 2 cuspid, and everything to start. We leveled the bite. We expanded this, and this down here, but kept it right. But we brought this back further up here and let this cuspid drop down. Kept these teeth pretty much where they were in the front of the mouth. Now, looking at this after we finish, this is not straight from the side, but you can tell this is a super class 1 relationship coming back to the back. So it's worked out great. On this side we got the expansion just about right. From the anterior you can see the depth of the bite and everything else. As we opened it, we opened the bite some. We've got a little midline deviation in here, and that may be something to do with two side discrepancies or something, but it may be I just didn't do it ideally to start with. However, these cuspids look pretty much the same out away from each other, so I don't worry about midlines being exact all the time, as long as I get the interdigitation of the teeth on the sides. Now, if we look at it from the side, this was way class 2 over here, and we're going to carry this back. We're going to also expand it, and then we're going to expand the heck out of this down on the lower part. And the bone structure stays with the teeth if you move a group out. And I've done thousands of teeth, and to my knowledge, I've not carried any of them out of the bone, unless I was mistakenly one time had a bracket that had a bad torque in it, and it took an upper lateral or something and almost had poked out into the palate up here, where it was the only tooth going in, but it would have gone through the bone if I hadn't caught it and changed the torque on that arch wire. The bracket had a false torque in it. I don't know how I got a hold of it, but anyway, this is working good. Now watch what happens. We'll change it. Now it's in class 1. We'll go back again and see how much that cuspid moved, how much these teeth moved in here, and I'll tell you there's bone structure on the buccal side of these teeth right here. I was lecturing one time in Colorado at a ski lecture, and a periodontist walked by, and I said, well, come in, and I was showing this case, and he just swore up and down that I had run these teeth out of the bone. And I just kind of hacked me off. I said, well, I'm not going to skin him just to show you this bone on these teeth. And the young man still had the teeth years later, and there's bone on them, regardless of what evidence he had. Said some German girl had been in a car accident and was killed, and she had some expansion of the teeth, and the teeth were out of the bone. Now, I don't know all the full situation on that. If they ran one tooth out to the side, if you tried to torque this tooth way out here, you might could bring it out of the bone. I have stripped lower anteriors by rotating them because the thin side would be next to the tissue. As you turn them around, they'll nearly always strip in there unless you could torque them from the edge of the teeth. Anyway, there's bone structure on those teeth. Okay, this came back, and you see what happened to the upper arch. Now all this is just routine orthodontics except the expansion part, and that's what I wanted to get across in this. And there it is after, that's 10 of 91, and there we put him in a retainer in 92. And I hope you remember that about retention. Now if you look at this a few months later, those teeth should be closer in contact. Over here it's pretty much contact. It was pretty well contacted when we started. And we put a 3 to 3 down there to hold that out, to hold that expansion we made. And you would want the person to wear this. Now we use a kind of a multi-stranded wire, and we bond it to all these teeth. And they keep that as long as they will, as far as I'm sure. That'd be better just to keep that indefinitely. Here we are on the x-rays again. I've got these roots a little close together right here, but that's not going to be a big problem. The crowns look pretty good. This one really needs to come over, and maybe we do get it over a little bit further down the line, but I don't show it. So that's the end of that particular case. And we're going to start another one here, and this is one that I want to show you. This young lady was not a patient of mine. I got these pictures from a young man who had taken a lot of courses from me, and he was in a study club, and this young lady has almost exactly the same problem, except on the other side of the mouth as the young man that you just saw. And I want to show you what was done to her by a group of, there was some oral surgeons and I think some orthodontists in it. And this young man I'm telling you about happened to be in this study club, and he voted against this, and he showed me these pictures. Now this is the left side of the mouth. She's got a tooth out over here, no big problem over there. They were going to put implants, and they did. The right side of the mouth is in crossbite, very similar to the side that you saw in the case. These teeth were meeting. We call it a scissor bite. That's a kind of a odd name to give it, but slides past kind of like a scissor. And so the solution to this, to me, is absolutely ridiculous. They extracted these 3 good teeth, maybe expanded the bone, and put some implants leaning out like this with crowns on them, because they didn't think that the bone structure would follow these teeth if they just brought the teeth out. Now that just gets under my skin. I just want to, that just tears me up that people do that. Now this was done 20 something years ago on the case I did, and it's 20 something years later, and we're still doing this stupid kind of treatment. That just gets me. Now here the teeth are a little, maybe slightly further in, maybe it's the way the models are meeting, but not much. And I'll guarantee you, if you put something on here and just expanded these teeth out, the bone structure with those teeth would go right out with them. Now, they just do not believe that. So they came back and extracted the 3 good teeth on that side of this young lady's mouth to do this. Now the other side, I've just got some little pictures here that I had to photograph. That's all I've got on her. And this side right here, they took those teeth out and put implants in there. They may have spread the bone or something to get these implants where they could put crowns on them that come out here and meet these other teeth. And that just kind of gets under my skin. Now this side is the same, and here we are. These three good teeth that this lady has. Uh, this is a terrible Panorex, just a photograph of a Panorex. It's not very good, but those teeth are going to be taken out and implants put over there. And this is looking through cephalometrically. You pick up the tooth from the other side. Now here it is. They've gone in, they've got something in here that I'm not sure. Maybe they were expanding the bone structure to put the implants in, but they took the three good teeth out the woman had, and then came in, and they look like they've got tads in there somewhere or another pulling this. I can't tell exactly what they've done there. Now there the teeth are in there, and there they are gone. They extracted those teeth to do this. Now there are these pictures, the three pictures. You can see the teeth are gone and the little heads of the implants are sticking up there. There's the implants. These are not good pictures, but that's all I had to show. And so I'm not criticizing these guys. Well, I guess I am, but they have been taught wrong, and that is not good. So here the teeth are, and there the implants are. Now, I'm going to try to get this on YouTube and Vimeo and wherever it goes, that people can see this. Now this is done just recently. This is 2013 when this was done. Now they were picking these teeth up. I see they've got a tad up here holding this in, and maybe holding these teeth up while they were doing this work to keep them from dropping down in here. And to me, this is absolutely ridiculous. I hope I don't know any of the guys that did this, or they don't know me. When they could have just put some expansion, the teeth would have moved out, and that alveolar bone would have gone out, and I'll guarantee you this basal structure that holds the alveolar bone would have shifted to support it after a period of time, and the woman had her three good teeth at least. And so this is, to me, ridiculous. So I'll go on from there. There are the implants. Maybe I've said too much about it, but anyway, I hope to God that people will catch on to something. We've done lots of surgery on people that we don't need to do the surgery. A lot of ridiculous diagnostic stuff here. If they knew a little bit about the movement of bone structure with teeth, that wouldn't take place. Now they put teeth in there and they fixed it up, and they were showing this case off. I mean, and to me it was absolutely ridiculous. Okay, here's another case. This lady worked for me, and she had a very narrow arch. She also had a TMJ problem, and so we had to advance her mandible and put her in a splint and got her jaw further forward. And we had to start with, we've got real narrow arches, and she had a breathing problem from youth up, and we put a palatal separator on her, and she's 32 years old, and that's in itself something you've been told that you couldn't do, but we figured out a way to do it. We put a spring in between the teeth up here with a lot of force on it. The major part of the bone structures right in here, and your palatal separators back in this part of the mouth, pushing apart. It's trying to push apart. The bone in here goes apart a lot of times, but you can't make this go apart. So we put pressure out here, and we're able to separate people in their 30s and even some of them in their 40s. I went up to Donald Timms, the guy that wrote the book from England, and at an annual meeting one time he was over speaking, and I asked him, how old you could separate. He said about 17 or 18. After that, you can't do anything, and I just walked away because I'd already separated people in their 30s and at that time. So you can do that. That happened on this particular case, but that's not what we're after here. I'm going to show you this large arch, how we expand. We put an arch for our Big Daddy in here, kind of a special one to bring it apart in here. And you see how close these teeth are together. Now there's been preached and everything else that you cannot expand the cuspids. They'll all go back in 10 years. And so I heard that years ago and I just did not believe it. Though it was, the research was done by a wonderful man, Dr. Little out in Washington University, and just the finest gentleman you ever run into. But he, to me, they made a mistake in here because I've gone against that for years and had a case there that expanded the cuspids almost twice of what they were, and it's 20 years out and it still was out there, see. And I've expanded I don't know how many bukus of people with cuspids expanded. I think the problem, if the cuspid is leaning like this and you just push it back and it's leaning more and you leave it alone, it'll try to sit up over the root. But if you bring the blooming root back, when you bring the cuspid back, we're not having that kind of trouble. So that's just a little something you might want to remember on this case also. So here we had a TMJ problem and we had a class 1 relation over here. I mean, things look great on this side. That's on the right side of the mouth. It looks good. Now, on the left side of the mouth, we've got a class 2 problem in here. And so, but we've got a TMJ problem. And so to solve the TMJ problem, we have to advance this tooth out to somewhere along in here. So we take the class 1 side and then it becomes a, to bring it out, it becomes a class 3. We got a class 3 problem over on the right side now, and we've got a class 1 problem on the class 2 side. In other words, we brought this forward where this molar's out in here somewhere, and that's a class 2 problem we've got there now. So we change from a class 2, class 1, well, actually we've changed this class 2 to a class 1, so it's no problem after we advance the mandible. Then we've got the class 3 side we have to deal with, so it changed it quite a bit in doing the TMJ stuff. Now, all this baloney about orthodontics having absolutely nothing to do with TMJ, that's about as bunch of bull as I ever heard. So it has a lot to do with it, and so you need to know something about the TMJs and how it functions and everything. If you're going to do orthodontics, there's no way to keep TMJ problems out of orthodontics. It's just mixed in there, impossible to separate the two. So that's my thinking on that. Now we went in with, at age 32, with a palatal separator and pushing it back. Now the major part of the bone's right in here, so we had to come in here with some spring and pushed it apart there, and we got her apart. Now she worked for me, and she's had this breathing problem all of her life. She's had a collapsed nasal airway from the beginning. And she said 2 weeks after we were into this and separated that, she could breathe better. In other words, it separated the palate. It'll push this apart. It makes the palate drop down as it goes apart, and it also widens it out. So the air space up here is a great deal bigger when you get through doing this than it was to start with. And so maybe you could have allergies and still breathe if you had a big enough hole up there that the allergy couldn't close it. Now we did a kind of a special Big Daddy arch here, which you really don't have to make. So I but we sat down and figured out how we could do that. So I made the arch wire come back and come around like this, and it would be sticking out, and we brought it in, and that was the first time I didn't quite see how I could expand down here without this arm in here. And that spread this out down at the bottom. Now these teeth are periodontally involved, and they don't have the best bone on them to start with, so you really don't want to put a lot of pressure on them. So we just took the cuspids and everything and went apart with that down in that area, and we expanded the heck out of it. And it's still out there. I know this girl. I mean, she worked for me for years, and she went to Atlanta, Georgia, and worked for some pedodontists there in Atlanta, and did the orthodontic part in the pedodontic, or was kind of managing the orthodontics under the pedodontist, of course. Now here is the palatal separator where we've tied it off. I like to band every tooth that I'm using in it, preferably so it carries the roots out. At the same time, it carries the crowns out, and that bringing the roots out is what really enlarges the airway. Now, we show this after it's brought back together, but when we first opened this up, it had spring in here, there was a space here, and then you let the teeth come back together in this area, right up in the front part of the mouth. Now, I don't see anything special about it down in here. We expanded that out, and we even got the lower anteriors had some space in them after a while. Now here was this kind of we call it a super big daddy, but you don't really have to use this. I'll show you how this, and you can just kind of forget this one. If you just learn the regular big daddy arch wire, you make it fit back here, and then you have space in here, and then you just tie these teeth to that space, and it'll expand this part while it doesn't expand the molar area back here. You don't have to build all this. This is pretty difficult to build, and have enough trouble with people learn how to do the easier things that we go in and wire bending. There it is in the mouth. Okay, and there's the expansion on the palatal separator that we got. Now look, take a good look at this. This is where these cuspids are now, and we got gaps between some of these teeth down on the bottom. No problem lining them up. And this was done with this big daddy arch wire. But all you'd have to do is just take a regular one and just make it out away from these teeth, you see. Then you could tie these teeth to it, and it would expand it, and you wouldn't have to make all this extra stuff to go on there. So I've got these pictures in here, but I wanted to show exactly how we got this lady's teeth apart. Now she's 32 years old, and we expanded the teeth, and they've still got the bone on them. You don't have to jump up and down then the bone's gone because we've expanded the arches, you see. So we've expanded the lower arch, and this is greatly increased across here. Let me go back and just show that again. Look at the difference in there, man. Now I don't have to have it that big. I got them out there so I get those roots of these cuspids, and I want them to be behind the crown, so the cuspid is leaning this way, so it doesn't tend to crawl back up there and crowd it up anymore. Okay, you can see the expansion. There's no problem in that, and we got the teeth out and expanded it. Now we had a TMJ problem, which and we did this case in 11 months, but the girls got together and took them off, and I didn't tell them to. We had her where she wanted to be, and they came out of them too quick, and so they didn't stay in there long enough to get this class 3 situation solved. You know, we had her wearing class 3 elastics over here, and this side was pretty much like we wanted it. You know, we didn't need any. It was class 2 to start with. We didn't have to wear anything. It stayed in position, but she didn't wear enough class 3 elastics to shift this whole jaw back. But it's looking good, and I'll show her to you many years later, and she's got a beautiful set of teeth even today. So this class 1 side now is out there, but it's kind of brought out, correcting the TMJ problem that she's got. Now she wore the retainer though. You can see this little track in the roof of the mouth. So she was wearing the retainer, and the retainer they first made is when we got a bunch of these dumb colors for acrylic, and so they had to make a retainer out of that colored stuff, which is kind of ridiculous, but anyway, people like it, so we make them a colored one if they wanted it. Didn't matter. And here she is. I don't see the date on that, but it looks like she's edge to edge right there, but that changes over a period of time. They'll settle in, and I'm going to show it to you several years. This is 1989 right here, and there we bonded these teeth together. You can bet your life we bonded them. I mean, every one of them is bonded on. And husband worked for General Motors, and so he was transferred to Atlanta, Georgia, and she's a sharp woman. I mean, she really knew the orthodontics herself, and she went to work for a pedodontist in Atlanta, and then he transferred back over a few years and came back, but she never came back to work for us, but I got to see her several times later on. Now we put a little ramp in these cases where we've advanced the mandible and bring them out a little further, where they close in there and they stay out there. If they stay long enough and don't go back and forth, the whole condyle fossa mechanism back there kind of remodels, and I've had some after 20 years, you couldn't get their jaw back to that position, so they'd remodeled. Now she's wearing a retainer, you can tell. This is 1990, and she still has too much vertical height of the face. Now, if she opens her mouth or smiles a lot, it completely masks the excess vertical height that you have in your face, and she looks beautiful there. And but if she closed her face originally, see, her jaw was way back here, so we advanced it out and brought it out here, but you just can't hardly reduce the vertical in doing orthodontics. You have to go in and do surgery where they take the maxilla loose and cut off a bunch of it or something like that. But we've been able to mask that a lot with non-surgical treatment of class 3s and things like that. Now look at the difference it makes in somebody. So if you have a high angle case, just smile a lot. Tell people to just smile. I know Carol Burnett in her program, when before she had all this surgery done, you never saw her with her lips together. She'd look ugly. And if Eva put her lips together here, it would show up. But if you're smiling, she looks great. You know, that's great. So if you have somebody you can't lower the vertical, just tell them smile a lot. Just keep your mouth apart like that. You cannot pick it up at all, hardly, from that angle. Now here she is. That's 10 of 90, and it's coming around looking pretty good, but the class 3 side is relapsing a little bit. You see the midlines moving over, and we put her in. We've got a retainer with a bite plate, so it can't go down, and it'll stay pretty much in place, you know. And we got a little ramp. Sometimes we make a night and a day. If they got to advance the mandible a long way, then we'll put a large ramp, and they wear that at night, and they wear a small one in the daytime when they're conscious of it, you know. Okay, this bonded on, and this is 90, and here's the x-rays of it. That's 88 when we started. She had periodontal problems, and those lower anterior were a little mobile when we actually started her case, and they're still doing good. Now there she is with the, you can see this big daddy arch wire in there coming back, expanding these teeth out like that. And we didn't put any weight on these little bitty anteriors. We just brought the cuspids and everything, cuspids, bicuspids out, and left them there. Here we're cranking this apart at 32, and it went apart, and her breathing was much better doing that. This is 89 again. That's 11 of 89. But you see the periodontal pocket she's got. Excuse me, I went past that. This midline is off, so it's relapsing a little. They just worked for 11 months and they came out. She should have stayed in this another 3 months to me and used a class 3 elastic. When she went to Georgia to work, she got somebody to put a graft down here, afraid that the bone structure on those teeth wasn't the best, and it was pretty bad when we started. They were very loose teeth. So anyway, this is settled in now. This is 92. You can see this very little space in between the teeth, and on the right and left side, both have come together quite good. That's not a real good photograph there, but now here it is, 92, and she is religiously wearing this retainer and keeping the bottom taken care of too. And there she was in 88 when we started, and there it is in 97. So that's 9 years later, and I've seen her way up in the 2000s, and that was 89, and there it is in 98 or something, 88, and that's 10 years later. You can see the crossbite in that area. That's corrected, and that's 92, 88, 97, 88 again, 97, and that's the way her jaw was, and we brought it forward there. It's 2006, and it's still there. The cuspids are still where they were. The lower anteriors are still lined up. That's 2006. This is relapsed some over here. This is a class 3. She didn't pull on this hard enough, and it's relapsed to some extent over there, but still looks good. The bonded 3-3 is still there. Stain, she smokes. That's another problem, especially with periodontal. It's 2006, so this is a long time after we done this. That's 2006. Let me see, I don't know, this last bunch is later than that. It's 2010 or something. And she's still got a beautiful smile, a beautiful set of teeth, and even closing the lips doesn't look too bad now. So she's breathing good and pressing on that. The case may have gone down to some extent, but you have very little success in closing an excess vertical of the lower third of the face. Orthodontically, it's very difficult. But this looks pretty darn good. Now, after 20 years or something like that, with her swallowing correctly and everything, maybe she has actually lowered the vertical dimension of the face. Now, that looks pretty doggone good right there. It's not very much. That's 06, I see. And there it was to start. See, she has actually lowered that. That's where she closed down before, and then look at the vertical here. So the vertical has gone down over a period of time by correcting function. So it's put pressure on the teeth, and so the vertical dimension has diminished, or has gone down, because it looks much better now. 2006, and this was about 87 or 88 or 89, somewhere when we first started. Now here's where we encouraged her to smile, you know. Now she's got a smile. You just don't pick up any of that, really. And so this is worth doing, you see. The different things that you're going to be involved with, and you can expand teeth, you can open the palatal separator and split the palates in people in their 30s, and they've even done a few in their 40s, and you can expand the lower anterior teeth and they don't go back in 10 years. And I'm sorry for the Dr. Little was such a nice guy, and I think he made a mistake there though. Here's another case we've done. This is a lady that worked for me, and we learned a few things about orthodontics, treating your assistants. She had TMJ problems also, and she has a real narrow jaw. Now it's class 1 on that side, and it's slightly class 2 over on this side, not very bad. And she has these little narrow arches kind of headed like this, and so we're going to want to expand these arches. I had a TMJ problem, and I didn't want to take any teeth out on her. So what we did, we just expanded everything. And you can take somebody with a kind of a pointed arch like this and expand it, bring it out, and actually bring these teeth back. She was a little protrusive, but so you can retract the anteriors by actually widening out the teeth in the buccal area. So you have to look at that. Now see how narrow this lower arch coming down like that. So we're going to come out with not that far, but we'll come out quite a bit, and that'll bring this back some as you expand the teeth buccally. And here, so just watch it. This was 87 again, and she left her husband. They moved to another town later on, but she had worked for me for a long time, and we had a little expansion problem in there where you get a little stripping of that tooth. And I don't know whether I brought it about or not. I've been talking that I never did one, but on lower anteriors you will get some stripping if you have to rotate them a lot and do a lot of work with them. Okay, here we're going to widen this arch, and we came in and put blocks on her teeth, to open it. And the TMJ problem in her case was had to advance her mandible. Now this, we put the brackets real low on these people. You can take these brackets and go down right on the gum line if you want to, and you go back up as long as you keep the incisal edges of the teeth lined up. You can take the brackets up and down, but you have to make a compensating bend in the arch wire to do it. Now here we use both upper and lower Big Daddy arches, and we expand this area of the mouth, and it brings this area in. She was too protrusive when we got this thing going, and I didn't want to take any of her teeth out, so we just laterally expanded both arches. And I put blocks on there to kind of get her closing where we felt like her jaw wanted to, and then we actually had her in a splint, which I don't think I've got any pictures of her in that, but we advanced the mandibles to a certain extent, and then I had to take the back teeth and elevate them, bring them together, and then when I got them touching, we took these blocks off and then set the teeth up like that. That's a kind of a hard way to do it. That's so complicated. I don't want anybody to try that. So we took the arch wire and bent it up and raised this tooth up so it'd come in contact. Then when we got this chewing back here, we took her out of this. That's the way you come out of a splint back onto your teeth. That gets pretty complicated, so I don't even need to think about this one. I will cover how we come out of splints into orthodontics more thoroughly, and there's a lot simpler ways of doing it than this. So anyway, we finished Carol up, and she looked great. Got this little stripped area on the lower anterior, which may have had something to do with it. I don't think. I think it was pretty much that way to start with. But anyway, we got her lined up, and I brought her teeth back where these teeth were in, and she didn't look so protrusive. She just had a broader facial structure. And she moved down to a town not far from where I live, down in Glen Rose. It's up here in Granbury. Went to work for an orthodontist up there. And she was in there one day, had this beautiful, elegant lady that didn't need any extractions, and this orthodontist was going to extract her teeth. And Carol knew so much. She knew a lot of orthodontics. She knew that woman didn't need her teeth taken out. She followed her. The lady left and went out and got the car out in the drive in the parking lot. She went out the back door, went around to her car and said, "Don't you do that. You go into Hearst and let Dr. White check you." So the lady came in and we straightened up, and she certainly didn't need any extraction. She was a very elegant lady, and fixed her teeth up real nice without extraction. And she sent her daughter in from Granbury into Hearst, and we did both of them there. I told Carol, if this guy ever found out you did, he'd shoot you. You know? But anyway, that's life. Now Carol has stayed in that position, and her TMJ is not bothering her. Her jaw is further forward, and she meets real good. And that's a little off there, not perfect. But here we have a retainer with a bite plate that holds it in that position. And we've got this bonded in the back. And so here she is years later, and she looks good. She's still got the little stripped area. She probably should have something bonded across that, or some graft or something like that on it. Looks great. Now she wears a retainer with a ramp to hold her forward at night, or she did years ago. Of course, we finished her back in '92, something like that. And here it is, 2015 or so. So it's been a long time she's out, but she still has beautiful teeth. And I hear from her every once in a while. And there she is again. And she takes care of it, and she wears her retainer, and she works good. And there it is, 96. That's 87. That's 96. 96. That was 87. And see the difference in the size of we widened the arch out. That's a bigger picture too, but we did widen it quite a bit. And there's the lower arch, and then we widened it out too. And that pretty well covers the Big Daddy arch wire, and I hope you learn to use them. You just have to remember to put buccal root torque if you expand them way out a long way. So do that, and I appreciate you looking at this and listening to my gripes in here. But there's a lot needs to be straightened out in orthodontics. Now I'm going to discard those add-ons that we put in there, and this is the final section of Bill White's Big Daddy arch wire. So hope you all have a good, don't get too bored to death listening to it. Thank you very much, and I'll close this out right now. If I can find my mouse.